بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hi dear third year medical students, we will discuss today an important subject. It is protein energy malnutrition. This subject is very important because we are in developing country and we will face it a lot. Relationship of nutritional status to various aspects of health. Why we need good nutrition? Good nutrition important to maintain growth and development for pediatric age group, and also for physical fitness for pediatrics and adult, and mental reaction and learning abilities, and also to prolong life, and it produce resistance to infection. What's the relation between malnutrition and infection? Of course, if there is any suppression in nutritional status, this will affect and increase the risk of infection, and it increase risk in terms of the course. It will be intense disease and it will be severe. And in undernourished patient, when they got infected, the intensity of malnutrition also is affected, and this will lead to progressive nutritional depletion because of repeated infection cause nutritional depletion, and at the same time nutritional depletion will cause an increased rate of infection. So it is a vicious circle. Undernutrition causing infection, and infection it causes undernutrition. So what the effects of infection on the nutritional status? First of all, infection causes depressed appetite, and also the food intake will be less than expected or than normal, and they take less nutrient diet. And at the same time, if there is GIT problems, this will lead to absorptive defect in the intestine. Sometimes the main reason is malabsorption, and this causes undernutrition, and this undernutrition will increase the risk of infection. Also, whenever there is stress of infection, this will increase the nitrogen excretion, and this will cause negative nitrogen balance. That's why vitamins like vitamin A, vitamin C, and even zinc and other trace nutrient will be excreted in the urine, and it will be lost. As well as protein deficiency, it is most important nutrient, and sometimes it is deficit in our food, and if there is malnutrition, even iron, copper, zinc will be affected too, and each one of these has its important impact on nutritional state. So as we said, there is a vicious circle. What's the effect of malnutrition on infection? There is a decrease in resistance because of infection due to different mechanisms. First of all, infection will cause the malnutrition also affect immunity, because it will affect types of immunity. Affected here is the T-cell immunity, T-cell mediated immunity, which means there is reduction in T lymphocyte, and the response to tuberculin skin test will be negative. It will be felt even if the patient is tuberculous, but when we do the tuberculin skin test, it will be negative because the patient have no immunity at all. And there is mild atrophy in thymus, lymph node, spleen, and there is impaired phagocytic activity. There is also decreased ability of leukocyte to kill the engulfed bacteria. Even if it is engulfed, the killing ability is less, and decrease the killer cell activity. There is a decrease in the level of secretory IgA, which is present in the nasal mucosa and secretion, in the tears, duodenal fluid, and also there is reduced complement factor levels. We have to remember the malnourished individual usually have a normal number of B lymphocyte. It is not affected. It is the T lymphocyte which is decreased in number, not the B. So as we said, whenever there is undernutrition, the patient immunity will be suppressed, and this will increase the infection. And because of decreased appetite, decreased absorption, and increased utilization, because the patient in infection, they need more energy, and there is increased excretion. This will causes undernutrition if the patient is not properly fed. At the same time, undernutrition here will causes this we call the immune factor, and we have non-immunological factor, which increases severity of disease. Like it will affect the respiratory muscle activity, and also it appears to dehydration because of lack of nutrient and fluid intake, and defective in the cardiac function, and this will cause an increasing risk of mortality in addition to infection. And at the same time, here we have the poverty play a major role, because poverty causes decrease in the nutrient intake, and food security will be less applicable, and this will affect poverty affect living condition, poor living condition, and because of poverty there is pathogen load and enteropathy, and this will increase risk of infection. At the same time, there is decreased access to healthcare and decreased social support. So poverty causes more infection and causes mortality. So how do you find definition of the malnutrition? It is a pathological state which results from relative or it is absolute deficiency, or sometimes excess of essential nutrients. So malnutrition is a definition including both undernutrition and overnutrition. How we detect malnutrition? By clinical manifestation and clinical examination and biochemical lab investigation. Anthropometric measures, as we said, we have to take the body weight, the length or the height, and we have to take the head circumference, the mid-arm circumference, and so on. And we have the physiological state and test. So about epidemiology of malnutrition, 1.5 billion women and men, children, they suffer from malnutrition all over the world, and mostly in developing countries. And malnutrition causes 1/3 of the annual death among children, young children, below 5 years. If there is maternal malnutrition, this will cause low birth weight. And 20 million infants born with a low birth weight each year. 90% of this 20 million found in the developing countries. In many developing countries, 40% of young children are underweight, and the greater risk of disease and death. They have a higher risk of death because they are underweight. If they survive, they have an increasing risk of malnutrition, diminishing future and work capacity. It affects also physical and mental development, especially if it is severe and occur early in life. So the risk of malnutrition effect later on the mental development is higher when it is severe deficiency and if it is occur early in life, before the first 2 or 3 years of life. So what are the types of malnutrition? We have, as we said, first of all, undernutrition. Undernutrition when there is the consumption of food is inadequate, and it is inadequate for a long period of time, causes what we call marasmus and kwashiorkor. This is the marasmus, skin and bone, and the kwashiorkor, although they are edematous, they look healthy, but this is abnormal because this is edematous. And overnutrition is another problem. They result from overconsumption of food. There is excessive calorie intake and for a long time causing obesity. Specific deficiency, they result from either relative or absolute lack of an individual nutrient like vitamin A deficiency. When it is severe, causes night blindness, and as well as iron deficiency as an example. It will cause anemia. This means there is individual nutrient deficiency. But when we talk about a nutritional imbalance, there is in disproportion in nutrient taken, in essential nutrient, with or without deficiency. Sometimes they have no deficiency, but there is disproportionate amount. Some of the essential nutrients are taken in good amount and some are lacking or they are inadequate. So it is not a balanced diet. That's why we have to emphasize on the balanced diet intake. So the types of malnutrition in summary, there is undernutrition and overnutrition. Undernutrition mainly we have marasmus and kwashiorkor, and the overnutrition there is obesity. Now, protein energy malnutrition, what is it? It is a spectrum of a clinical disorder. It is not only one type of disorder. There are clinical disorders, and it is caused by various degree of deficiency. In addition to physiological insult, and stress. It is considered a silent emergency. It is a silent emergency of the world because it is hidden, and it is one of the most important nutritional problems in most of the developing countries. Why it is silent? Why we call it silent emergency? Because it might end with death, even in subclinical state, and it takes time to appear clinically. It causes permanent disability because most of the brain growth occur in early years of life, with increasing possibility of infection and decreasing resistance to infection. So permanent disability because of defective brain growth, and there is liability of infection more than others. So almost 150 million children less than 5 years of age affected by protein energy malnutrition. 150 million children. In Iraq, the UNICEF report showed that more than 20% of children below 5 years they have protein energy malnutrition. So this is the prevalence rate in Iraq. Below 5 years, 20% they have protein energy malnutrition. In children with protein energy malnutrition, they may result in wasting, stunting, and underweight. So what are the indicators of malnutrition? How do you know that the patient is wasted or stunted or underweight? First of all, we have to check the weight, and we have to check the height and compare to a standard reference and tables. So if the weight for height is low, this means acute malnutrition. Acute malnutrition, we call it the wasting. And we have certain standard deviation to assess, and it is also listed in the reference table. So the weight for height, if it is less than 2 minus standard deviation of the reference table, it is most easily reversed and treated, but often recurs due to infection. So we have to prevent infection. Prevalence of wasting in Iraq, also it was 9.3%. Also, as we said, it is below 5 years of age. This study by the UNICEF done in Iraq for children below 5 years of age. So if there is weight for height is low and it is less than 2 standard deviation, this we call wasting, and it is acute malnutrition. Now the other type we call stunting. Here the height for age is low. There is low height for age. This is indicate chronic malnutrition because it affects the length, not only wasting, but here we have a stunted growth. The length is affected. And the height for age is below 2 standard deviation of the reference table. So this is very difficult to reverse in children, especially after 2 to 3 years. And the prevalence of stunting growth in Iraq below 5 years is 20.4%. They are stunted growth. They are short in comparison to other children with similar age. Now we have third variety is a low weight for age. Weight for age, we call it the underweight. This is general malnutrition. And here the weight for age is below minus 2 standard deviation of the reference table. So it is a combination of acute and chronic. One or both wasting and stunting can result in underweight. So it is a mixture of both acute and chronic. And the prevalence of underweight in Iraq is 21.3%. So protein energy malnutrition characterized according to the severity to severe, moderate, and mild type. Severe, moderate, mild type. And the severe type presented as either marasmus, kwashiorkor, or also combination marasmic kwashiorkor. These are different types, as we said here. This is a normal child below 5 years. When he is wasting, there is low weight for height, the same height as normal, but the weight is less. So low weight for height. While stunted, the patient is low weight for age. They are the same age, but the height here, the height is less. So there is difference in height, the same age but less height. And the underweight, low weight for age. and this is acute and chronic. Low weight for age. The weight is affected, and even the length is affected. So it is acute and chronic. We have normal, wasted, stunted, underweight. And if we talk about overweight, we have to say there is other variety when the baby or the child is overweight as compared to a standard level. So we will talk now about a nutritional marasmus. Usually the child is less than 1 year. The weight for age is less than 3 standard deviation. Below reference weight for age table. Or we have other way to estimate it is less than 60% of the median weight for age. And we call that they are small for the age. If the child having weight for age is less than 3 standard deviation, or the weight for age is less than 60% of the median for his age, we call it marasmus. So wasting of the muscle is a clinical sign. There is subcutaneous fat. Also it is absent. There is hypotonia and wrinkled skin. And diminished height for age. The height is affected and they look emaciated. They are skin and bone. There is absence of adipose tissue and subcutaneous fat, and abdomen distended or maybe flat. The edema here is not noticeable. This is the difference between marasmus and the kwashiorkor. There is no edema. And there is subnormal body temperature. They are cold, slow pulse rate with reduced basal metabolic rate. They are inactive, they are inert. Constipation usually present, but sometimes there is diarrhea. We call it starvation diarrhea, which involve frequent small bowel motion with mucus. We call it starvation diarrhea. And they have retarded bone age. What about kwashiorkor? It is type of severe protein energy malnutrition. It is caused by severe protein deficiency. While in marasmus there is calorie deficiency. Here we have protein deficiency. Early clinical finding, not specific. There is apathy, lethargy, irritability. Usually here the age is more than 1 year. And the weight for age 60 to 80 of median weight for age. They are higher weight than patient with marasmus. In marasmic they are less than 60, but here they are between 60 and 80. Edema, there is edema. We call it non-pitting edema. When you press in the edematous site against a bone, it will not causing dimple. It is not pitting edema. And plump appearance, he looks plumpy, which means overweight or good weight, but there is round cheeks and round belly. Because of low protein, there is inadequate balance of water. There is retarded growth and loss of muscle tissue. There is loss of tone, anorexia. The patient is also having anorexia and hypotonia. They have decreased appetite, while in patient with marasmus, the appetite is preserved. He had appetite, but there is loss of energy. Food is less energetic food, although they are having good appetite, but the food they are taking are less energetic than required. Here there is deep dermatitis, darkening of skin in irritated area. There is dyspigmentation occur in this area, and there is ulceration, skin fissures, loss of hair elasticity, thin dyspigmented streaks, and red or gray hair color. This is a picture of a patient with kwashiorkor. You see the patient looks well, looks plumpy, means obese, but it is edema. This is not obesity. And the skin here, you see it, especially in the creases. There is depigmentation and hyperpigmentation. There is fissuring in the skin. And the patient is apathic. Okay. Mental changes, there is irritability, restlessness, and loose stool is common. They have diarrhea. In patient with marasmus, they usually got constipation, and sometimes they got, as we said, starvation diarrhea. But in patient with kwashiorkor, mostly they got diarrhea. Liver enlargement because of fat infiltration, reduce of fat mobilization due to decrease in lipoprotein synthesis. Growth failure, moderate anemia, retarded bone age, and low plasma protein, especially albumin. The albumin is less than 1 ml per deciliter. And if we have marasmus kwashiorkor present with a clinical finding of both marasmus and kwashiorkor, there is edema and there is a gross wasting and mild hair and the skin changes. So mixing picture between those edema and between the kwashiorkor and marasmus, call it the marasmic kwashiorkor patient. So the prognosis of severe protein energy malnutrition, mortality occur in 10 to 60%. Case fatality rate depend on many factors, like if there is any associated infection, the mortality would be higher, or other concomitant nutritional deficiency, not only the protein or calorie, maybe other vitamins or trace elements and so on. Delay in seeking treatment, if they reach hospitals lately, so this is getting a poor prognosis, or the rehabilitation center for nutritional rehabilitation, also it is, if it is late, this is one of the poor prognosis factors. And we have seriousness of the child condition at the time of admission. Sometimes they reach end state during hospitalization. So mild and moderate protein energy malnutrition, here the weight range between 75 to 89.9% of the standard weight for age reference table, or it is between -1 to -2 standard deviation below the reference weight. Here we have mild to moderate. It is not severe. Severe if it is less than a 3 standard deviation, but mild to moderate between -1 to -2. Moderate when the weight range from 60 to 74% of the standard weight for age reference table, or it is less than 2, -2 to -3 standard deviation below the reference. So mild, moderate are different from severe type. These children usually they are misdiagnosed unless their growth has been monitored. That's why we like to check the babies and ask the mother to check them frequently, and what we call this is monitoring of growth, as by this monitoring we may catch this infection earlier and this patient can be treated. And if there is any defect during monitoring of the growth, we call it here, it is malnutrition because of underweight caused by undernutrition maybe, and we have to search for the cause or the nutritional supplement. So the protein energy malnutrition, first of all, we have to know the etiology. Maybe it is immediate causes, like if there is any disease affecting the nutrient intake, maybe liver disease, heart disease, or maybe renal problems. So these chronic diseases cause decrease in intake, or sometimes it is due to poverty or inadequate dietary intake because of carelessness. So this is the immediate cause. Maybe we call it the primary causes, and we have underlying causes. This is secondary, either because insufficient food intake, here because of low energy and protein, stumble diet, and poor lactation, especially if there is no breastfeeding, and inappropriate use of infant formula, maybe over dilution, using water and excess than the powder milk used, inappropriate weaning practice, and they might wean the baby from breastfeeding earlier, before 2 years or even before 1 year, or because of maldistribution of food within the family and lack of food, ignorance, religious or cultural taboos, and inadequate care. This is social factor because of divorce, because of death of the mother, and so on. B, there is inadequate maternal and child care practice. For example, if the mother is malnourished, and if he is low birth weight or premature baby, or there is multiple pregnancy and the breast milk is not enough to feed them all, and if there is a large family size, short birth interval, and no immunization, and there is no growth monitoring. Other factors, which is here we call number C, there is insufficient health services and unhealthy environment, like no safe water, unhealthy environment, unavailability of drugs, and the health services availability, accessibility, and accessibility is affected. It is less than required. So the basic causes are poverty, wars, economic structure, political. These are the basic causes behind all of the other causes. What we can do to prevent and control protein allergy malnutrition: first, encourage breastfeeding. Second, extra meal should be given, and good feeding for sick child. And health education and nutrition education. And when there is inadequate amount of animal milk, select a good mixture of a favorable plant protein. We call it the protein complementary, not depending totally on animal protein. If there is deficiency, we have to add plant protein in addition. Also, prevention and control of infection by immunization, by health education, by proper use of antibiotics, not haphazard and offer every patient with diarrhea. Many of doctors, they use to choose antibiotic which cause harmful effect on the normal bacterial flora, and this will cause serious infection. Also, socioeconomic improvement and better food distribution. Growth monitoring is important for early detection of growth faltering, and adequate maternal and child care services for immunization, for monitoring, and for giving a special treatment for children, and also provision of safe water and good environmental sanitation. At home, proper management of food budget and improvement of food basket should be balanced diet, contain all type of nutrient required, and mainly it is protein content and carbohydrate. Community participation for early diagnosis, we call it the community care center, and they should supply or apply the good health services through primary health center, nutritional rehabilitation center, and pediatric units. Thank you.